Video, we will be going over the pharmacologic agents used for the management of obesity and the promotion of weight loss. Because I'm sure you have come across this now multiple times, but obesity is a major risk factor for a number of diseases, including diabetes, cardiovascular diseases, cancer, and many others. Now, obesity is a modifiable risk factor, unlike genetics or age, for example, so weight loss can produce a number of benefits, including risk factor improvement, prevention of disease, and others. Now, obesity management guidelines recommend non-pharmacologic measures first line, including our diet, exercise, and behavioral modifications. But in those individuals with a BMI greater than or equal to 30, or those with a BMI greater than or equal to 27 with some other comorbidity like diabetes, for instance, pharmacologic agents may be used as adjuncts to help provide a sort of kickstart to reduce food intake or increase activity, which may help amplify adherence to the obesity management plan. Because if you think about it, you are more likely to stick to the plan if you see results, especially early on. Now, as I just alluded to, sticking to an obesity management or weight loss plan can be challenging for a number of reasons. And one of those reasons is because there is a strong neurohormonal component that regulates appetite and the feeling of fullness or satiety, and hunger cues that can become dysregulated, making it difficult to find the correct balance between energy intake and energy expenditure. Now, this regulation is complex, and I realize you have not yet had neuro. So we will focus on only the key takeaways from the physiology and the pathophysiology necessary to understand how the drugs used for the management of obesity work. Now, the brain regulates food intake as a behavior, and it relies on information from the rest of the body and from the environment to make the decision to eat or not to eat. And we know the hypothalamus is the key brain region coordinating food intake, and it receives input from other brain regions, like those involved in the reward pathway, the sensory information, and emotional control, making the hunger signals even more complex. So the hypothalamus also importantly detects nutrient levels to help guide food intake behaviors. So there are two groups of neurons in this region capable of sensing these nutrient levels, the hormones that are released from the GI tract, and other tissues to serve as indirect messages about nutrient levels, and signals from the autonomic nervous system that originate from the gut. Some of the hormones released include leptin, ghrelin, GLP-1, which is released from the L cells and the lower part of the intestines and the colon, and GIP, which is released from the K cells in the upper part of the small intestines, with the latter two being key moving forward. So the neurons that respond to these inputs and lead to downstream orexigenic signals or appetite stimulating signals, we will refer to as AGRP or agouti-related peptide neurons. So these signals promote food intake, and this would be from low nutrient levels that are sensed, for example. The neurons that respond to inputs that lead to anorexigenic signals or appetite suppression, we will refer to as POMC or pro-opiomelanocortin neurons. And these would be stimulated in response to sufficient nutrient levels, for example. And these would lead to the satiety messages and eventually weight loss. And the POMC neurons will be the main focus for today. So let's move on to the next slide. Now, in obesity, there is a dysregulation of these appetite signals where there is an imbalance with increased AGRP neuronal signals and or reduced or impaired POMC neuronal signals. However, many of the pharmacologic agents will act in ways that lead to POMC neuronal stimulation and downstream signals of satiety, and which long-term will lead to that reduced food intake and weight loss. Now, for today, there are 6 separate drugs or drug combinations that are FDA approved for weight loss that we will discuss that modulate this neurohormonal regulation of appetite and satiety, and all will focus on either directly or indirectly promoting these satiety signals from our POMC neurons. Now, the first group we're going to discuss is going to be a refresher from block 2, and these are going to be our GLP-1 receptor agonists. Specifically, we're going to be talking about liraglutide and semaglutide, with semaglutide probably being the one you hear most often as Ozempic or Wegovy. And both of these are FDA approved for this use, in addition to their use in type 2 diabetes. So GLP-1 is this peptide hormone that falls into that incretin category. And these are going to be secreted by those intestinal L cells, primarily found in the ileum, after the ingestion of a meal. So we won't focus on the insulin-related mechanism of GLP-1, but if you remember from block 2, GLP-1 analogs promote insulin secretion in a glucose-dependent manner. But for weight loss, GLP-1 delays gastric emptying making patients feel fuller for longer. But more importantly, we'll bind those GLP-1 receptors on our POMC neurons to stimulate the release of those beta endorphins and other POMC-derived signaling peptides to promote satiety and downstream weight loss. So because we are administering a GLP-1 receptor agonist that is a protein, it will have to be injected sub-Q, right? Also, because of the delayed gastric emptying time, nausea is very common and can be dose limiting, and its insulin-related effects may lead to hypoglycemia. So there is a risk of pancreatitis with this agent. So counseling for signs and symptoms is important. And unfortunately, because we are supplementing a hormone, which is usually tightly regulated, this agent does come with a risk and a black box warning for medullary thyroid cancer and multiple endocrine neoplasia syndrome. So this agent cannot be used in patients with this or a family history of this, and patients should be counseled on the signs and symptoms of thyroid cancer. So more recently, and building upon these GLP-1s, is the recent approval of tirzepatide, which has been approved for weight loss, which you have probably seen commercials for as Mounjaro for diabetes and Zepbound for weight loss. And this agent is very similar to our GLP-1 receptor agonist because it is actually a dual GLP-1 and GIP receptor agonist. And this agent was developed for a few reasons. So this peptide was created as a mixture of amino acids from GLP-1, some from GIP, and some from both, and some that are actually unique to this particular agent. And it allows it to agonize these two receptors, but with greater affinity for the GIP receptors. And the hope is that this preference will actually minimize the risk of hypoglycemia seen with the GLP-1s and reduce that nausea also seen with the GLP-1s that can lead to therapy discontinuation. And the bias signaling at the GLP-1 receptor reduces the desensitization of these receptors, so they actually hang out for longer. So there can be some more sustained effects long-term of the GLP-1 receptor agonism coming from tirzepatide. Now, whether or not the GIP agonism coming from tirzepatide actually directly leads to a similar path of anorexigenic signaling and effects, or does this indirectly by increasing the tolerance window for the GLP-1 agonistic effect, it is still unclear. But we know that together this combined dual agonism should translate to more dramatic weight loss when compared to our GLP-1 receptor agonist alone. Now, for pharmacologic considerations, you can imagine much remains the same in terms of side effect profile, black box warning, and counseling points to improve adherence. So now moving on to our next agents that work via different mechanisms on our next slide. Our next two agents we're going to discuss come as a combination, and the brand name of the combination is Contrave. And Contrave is a combination of bupropion and naltrexone. So we'll start off with bupropion, which is usually thought of as a stimulating antidepressant. So on our presynaptic nerve terminals throughout the central nervous system, there are transporters that act to sort of recycle the neurotransmitters that were released from the nerve terminals into the synapse. So essentially, we're sending those released neurotransmitters back into the nerve terminal to terminate whatever signal was going on, so that it's not prolonged. And again, we're going to recycle those neurotransmitters for the next time the signal must be propagated. Now, the way in which bupropion works is to inhibit these catecholamine reuptake transporters, specifically our norepinephrine and our dopamine reuptake transporters, so that these neurotransmitters remain in the synaptic cleft so that they can bind their respective receptors, stimulating our POMC neurons, promoting their satiety signals, and eventually that weight loss. So because bupropion is a component of Contrave, there is a risk of suicidal ideation and thoughts and behaviors, which comes with all of the antidepressants. Also, because of this alteration in catecholamine signaling due to its mechanism of action, there is going to be a risk of hypertension and seizure, and a wide variety of stimulating side effects because of its mechanism. So for example, this agent should probably be taken in the morning to help avoid insomnia. So also because of the altered catecholamine release, there are a lot of drug interactions for this agent, because any drug with a similar mechanism of action or those that alter its metabolism or excretion is going to place the patient at risk of serotonin syndrome. And we won't get into this in too much detail here, and we'll discuss it more in later blocks, but this reaction can be life-threatening, and so a drug interaction checker is going to be really important for Contrave. So now naltrexone, which we discussed for alcohol use disorder in block 3, is combined with bupropion in this Contrave combination to help with the promotion of weight loss, still acting as a mu-opioid receptor antagonist. So on our POMC neurons, mu-opioid receptors are found on the presynaptic nerve terminals to provide a negative regulatory feedback. So usually once signaling has been sufficient from our POMC neurons, beta endorphin, which is one of the POMC-derived peptides, will bind the mu-opioid receptor to help terminate the POMC neuronal signal. However, with naltrexone on board, we're now antagonizing this negative feedback receptor so that this regulation is lost, and the POMC neuronal signal is perpetuated to promote satiety and eventually weight loss. So because of the naltrexone component of Contrave, patients do have to have an opioid washout where they have been at least opioid free for 7 to 14 days, depending on how long acting the opioid was that they were on. And this way we avoid triggering withdrawal. And as we discussed for block 3, monitoring for hepatotoxicity will be necessary. So now our next two agents that we're going to discuss also come as a combination, and they are phentermine and topiramate, which is the brand name Qsymia. And also phentermine can be used alone, but only short-term for weight loss. So we will start with phentermine, which is a sympathomimetic amine that acts similarly with stimulant activity as other agents like amphetamines. And phentermine works to suppress appetite by stimulating the release of catecholamines like norepinephrine and dopamine, and by working like bupropion to inhibit catecholamine reuptake by inhibiting these reuptake transporters. So now not only do we have more neurotransmitters released, it is going to hang around in the synaptic cleft for longer to promote the signal stimulating our POMC neurons and the downstream appetite suppression. So because phentermine is a stimulant, there is a risk of misuse, and it is a controlled substance. So there are regulations around the prescribing of phentermine alone and Qsymia. There's also going to be other risks related to the stimulant effects, like it's going to be contraindicated in cardiovascular disease, glaucoma, and hyperthyroidism as examples. And because of its mechanism of action, similar to bupropion, there is also going to be a risk of drug interactions and that serotonin syndrome. So the second component of Qsymia is topiramate. And this component doesn't really have a very well-defined mechanism of action. But it technically falls in the anti-epileptic drug category. But it has been shown to suppress appetite, and this may be through the hypothesized modulation of GABA or glutamate signaling, sodium channels, and carbonic anhydrase inhibition. Regardless, when it is used for seizure disorder, for example, weight loss and loss of appetite are very common side effects, which is obviously going to be advantageous here. So for important considerations for topiramate, it is going to come with a risk of metabolic acidosis, memory impairment, and altered cognition, as well as paresthesia. Also, there can be CNS depression, so fall risk counseling will be important, and avoiding with alcohol. So overall, just a lot of CNS-related side effects. There's also going to be a risk of Stevens-Johnson syndrome or toxic epidermal necrosis, and we're going to have to start low and titrate up. And there's also a risk of seizure with abrupt discontinuation. So the patient will also have to be titrated off of this agent. And topiramate is very teratogenic, and it is contraindicated in pregnancy. And on top of that, a lot of anti-epileptic drugs like topiramate can induce CYP enzymes. So this would increase the metabolism of things like hormonal contraceptives. So additional forms of contraception is going to be recommended, and negative pregnancy tests throughout therapy will be needed. Now, there's one last agent that we need to discuss that is approved for the management of obesity and the promotion of weight loss, but it has a very different mechanism of action from all of these agents we just talked about that try to correct this neurohormonal dysregulation of appetite and satiety. And this last agent is orlistat. And orlistat is available over the counter as Ally, or at a prescription higher dose, the version is called Xenical. And how this agent works is usually when a meal is ingested, a number of lipases from either the pancreas or the gastric lipases will act upon the ingested dietary fat to break it down from triglycerides to fatty acids and monoglycerides, which can then be absorbed and either used or stored in the body. So orlistat actually covalently binds and inhibits these lipases to prevent this dietary fat breakdown so that it's never actually absorbed and it remains in the GI tract to be excreted, essentially creating a caloric deficit and eventually weight loss. So this agent can inhibit dietary fat absorption by about 30%. And the bonus is that orlistat is not absorbed and works locally. So a lot of the systemic side effects that are concerning for the other agents we discussed today that act centrally are less of a concern now. But one of the main issues with orlistat are the GI side effects, like oily stools and fecal urgency, which is really common based on its mechanism of action and a big influencer on patient compliance. And the higher fat content diet you eat, the worse these side effects can be. And lastly, there may be a reduced absorption of fat-soluble vitamins, so patients need to take a multivitamin that is at least separated from their orlistat by 2 hours if they are going to use this agent for weight loss. So moving to the next slide. So I hope this video has provided an overview of the few pharmacologic agents we have that have been approved for the management of obesity and the promotion of weight loss. Now, I realize a lot of these agents target the neurohormonal regulation of appetite and satiety, and you have not yet had neuro. So the big takeaway from these agents and their mechanisms of action is that usually they are thought of as either an antidepressant, a stimulant, an opioid antagonist, or an anti-epileptic drug, but they all have this unique mechanism of action that converges on this promotion of POMC neuron signals that are going to promote that satiety and eventually that weight loss. And then furthermore, because these agents all work centrally to alter this neurohormonal axis, the side effect profile for these agents is going to be very different from, say, orlistat, that is not absorbed and acts locally. So the mechanism of action and side effect profiles for these systemically acting agents will be revisited in future blocks. And hopefully this will serve as a nice introduction for some of these agents that we are going to revisit for other indications.